Good morning, everybody. It is really a matter of great pleasure for me to come back to Kerala State after a very long time. I started my ENT practice in Kerala State way back in 1996. My first endoscopic pituitary surgery was again way back in 1998, along with one neurosurgeon, Dr. Kurian, who was a product of Sri Chitra Tirunal Institute, Trivandrum. Trivandrum is specifically very dear to me because I started my academic career by presenting two research papers during South Zone conference held at Kovalam. Trivandrum is also very dear to me because in year 2000, me and my wife we celebrated our honeymoon in Kovalam. I thank Dr. Vinod Felix and his team for having given me this wonderful opportunity to come back to Kerala State again. However, due to unexpected family emergency, I have to go to United States of America and therefore I cannot be with you today and I'll be missing this wonderful program. Nevertheless, I do not want to miss the opportunity to share this small knowledge of mine with you all. I again thank Dr. Vinod Felix for having given me this opportunity. I bring hearty greetings to all of you from my hospital, Karnataka ENT Hospital and Research Center, and also from my historical city of Chitradurga, which is famous for its most impregnable fort in the world because it has 7 layers of fortification to prevent enemies entering inside. This morning, I am pleased to share my knowledge on imaging for endoscopic skull-base surgery. Due to time restrictions, I restrict myself to endoscopic skull-base surgery. After all, it goes without saying, one should venture into skull-base surgery only if they are very well versed with endoscopic sinus surgery. I presume that you are all masters of imaging for endoscopic sinus surgery. If somebody is interested, they can access my book on imaging for endoscopic sinus surgery, a handbook published in 1997 but contemporary even today. It is freely available on our hospital website www.kenthospitals.com/IASS. Famous English writer Mr. Rudyard Kipling, who wrote many stories on India like The Jungle Book, said, "There are only 6 honest serving men in this world. They are what, where, why, when, and who, and how." This applies to our daily lives also. If we want to get something in life, we have to ask for it. Unless we ask, we will not get anything in life. One needs to develop a childlike curiosity to learn and master anything. I call this 5W1H principle. This applies to imaging for endoscopic skull base surgery also. If you want answers, ask images, questions. Goals or objectives of imaging for endoscopic skull base surgery. The radiological investigations must provide the following information. First and foremost, it should identify the lesion without fail. Next, it should clarify us the exact site of origin of the lesion. Third, it should differentiate the anatomical relationship to the neighboring structures. Fourth, the imaging modality should be able to differentiate the pathology and provide us a working diagnosis as well as differential diagnosis. Next, fifth point, it should help us recognize tumor infiltration. Sixth, the imaging modality should help us assess the vascularity of the tumor as well as proximity or infiltration of the tumor to neighboring vessels. Seventh, the imaging modality must distinguish the tumor from normal structures. Last but not the least, the imaging must help us plan our surgical approach and it should provide us a route plan. Important imaging modalities used are computerized tomography scans, magnetic resonance imaging films, digital subtraction angiography, positron emission tomography scans, MRI angiography, and now CT angiography with volume rendering using 3D reconstruction, which depicts the picture in 3D reconstruction. Computerized tomography is helpful in assessing degree of pneumatization of the paranasal sinuses and to study the integrity of the medial wall of the orbit and cribriform plate. It is also helpful to study the location of the intersinus septa in frontal sinus and sphenoid sinuses. The position of the anterior skull base vessels can also be studied. CT angiography is particularly useful. The relationship between the fovea ethmoidalis and cribriform plate can also be studied using computerized tomography. Computerized tomography is helpful in identifying anatomical variations such as 1OD cells, basilar expansion of the sphenoid, pneumatization of the anterior clinoid process, supraorbital ethmoidal cell, dehiscence of the medial wall of the orbit with protrusion of the orbital fat tissue toward the ethmoidal labyrinth, and dehiscence of the lateral wall of the sphenoid. The presence and extent of bony dehiscences in the skull base near the internal carotid artery, optic nerves, and cavernous sinuses. For skull base lesions, MRI is indicated to establish the following: 1. Recurrent skull base tumors; 2. The intra or extraaxial origin of tumors; 3. The type of tissue located adjacent to dehiscent or destroyed bone; 4. The invasion or external compression of the brain. MRI is used to study the involvement of the internal carotid arteries, cavernous sinuses, vertebrobasilar system, and dural sinuses. MRI is also study the anatomical areas of potential major risk for a surgical approach, such as cavernous sinuses, Meckel's caves, optical nerves, internal carotid arteries, vertebrobasilar system, and jugular foramina. Basics of MRI. Now I am sure you all are adept with reading CT scans, as you are all already accomplished endoscopic sinus surgeons. Many of you may also be adept with MRIs too. However, this is for the beginner. MRI has become mainstay in skull-based surgeries. MRI is versatile and MRI is dynamic. There are more than 20 different types of modalities of MRI protocols which fulfill all the objectives of skull-based imaging. However, commonly used are T1 and T2 weighted images. The T1 images are popular as structural images, whereas T2 images are popular as functional images. One need to understand the difference between T1 and T2 weighted images to study the images better. The air, fast-flowing blood, and mineral-rich tissues depict themselves as dark color in T1 weighted images, whereas the same air, fast-flowing blood, and mineral-rich tissues depict as dark color in T2 weighted images also. The eye-free or bound water tissue show themselves as gray color in T1 weighted images, whereas in T2 weighted images, the collagenous tissue, bone islands, and high bound water tissue show as gray color. The proteinous tissue, they show up as light gray color in T1 weighted images. In T2 weighted images, the high bound water tissue, a fat and fatty bone marrow, they show up as light gray color. The fatty bone marrow, blood products, slow flowing blood, radiation change, and paramagnetic contrast agents, they show up as bright color, a white color in T1 weighted images, whereas the fatty bone marrow, high free water tissue like CSF, and proteinaceous tissue and blood products, they show up as bright a white color in T2 weighted images. Continuing with the basics of MRI. Though T1 and T2 weighted images are commonly used, one should be aware of other modalities of imaging also. You are already aware in T1 images, the white matter appears as light gray color, whereas in T2 weighted images, they appear as dark gray color. The gray matter appears dark gray in both T1 and T2 weighted images. However, The CSF appears dark or black in T1 weighted images. CSF appears white or bright in T2 weighted images. The FLAIR images, also known as fluid attenuated inversion recovery sequence. The FLAIR images are heavily T2 weighted images with CSF signal suppression. They highlight hyperintense lesions and also they improve their conspicuity and detection, especially when located adjacent to CSF containing spaces. They are used to evaluate diseases affecting the brain parenchyma neighboring the CSF containing spaces, for example, multiple sclerosis and other demyelinating disorders. The next images, the also known as diffusion weighted images or DWI images. The primary application of diffusion weighted images or DWMR imaging has been in brain imaging mainly because of its exquisite sensitivity to early detection of ischemic stroke. They are also useful in assessing extra-axial masses like arachnoid cyst versus epidermoid tumor. They are also used in intracranial infection and in pyogenic infection conditions. ADC or apparent deficient coefficient. It is a measure of diffusion calculated by acquiring two or more images with a different gradient duration and amplitude. They are used to differentiate T2 shine-through effects or artifacts from real ischemic lesions. The ADC may be useful for estimating the lesion age and distinguishing acute from subacute DWI lesions. A tumor would exhibit more restricted apparent diffusion compared with a cyst because intact cellular membranes in a tumor would hinder the free movement of water molecules. The next image, that is contrast enhanced MRI. These are T1 or T2 weighted images obtained after injecting contrast agent like gadolinium. Though this contrast agent does not cross the normal blood-brain barrier, they are not blocked in the blood vessels generated by the tumors. Therefore, they provide information about physiologic tissue characteristics. Next, GER, gradient recalled echo. The technique is particularly useful for diagnosing hemorrhagic contusions, such as those in the brain, and also assess the calcified lesions. The next, the magnetic resonance venography. MR venography is used to assess abnormalities in venous drainage of the brain for evaluation of thrombosis or compression by tumor of the cerebral venous sinus in members who are at risk. For example, otitis media, meningitis, sinusitis, oral contraceptive use, underlying malignant process, and hypercoagulable disorders, or also who have signs or symptoms of papilledema, focal motor or sensory deficits, seizures, drowsiness, and confusion accompanying a headache. The MR venography are also known as, there are two types of MR venography. The first one, also known as two-dimensional venography or time of flight sequences, such as this one. And also there is another MRV, three-dimensional venography, also known as phase contrast PC or PC series, where we can get a three-dimensional picture. And the last one, the MR angiography, is for examination of arterial blood flow, and unlike traditional angiography that involves catheterization, MRA is non-invasive. Methodology of assessment. When you start assessing radiological films, you need to make your objectives very clear. You need to answer certain questions to yourself, and those answers will guide you how you will progress with your case. First question you need to ask yourself is, what is your area of interest? Once you are clear about it, ask yourself, what are the normal contents of this particular area? This needs extensive knowledge of anatomy. Third question is, what are the radiological pattern of the disease? This question demands knowledge of various pathologies. Fourth, ask what are the possibilities of differential diagnosis. Fifth, ask how you can integrate those radiological patterns with the clinical findings of the patients. Sixth step, with this combined analysis of radiological patterns and clinical findings, arrive at a probable final diagnosis. Seventh step, ask what is your approach or the flight plan. Look for favorable points or obstacles for your approach and prepare yourself for it. The last step or eighth step, ask yourself whether the intended approach is efficient to achieve your objectives and is it safe. Looks for obstacles and limitations. Two laws of endoscopic skull-based surgery you must remember when you assess the scan at this moment. Rule number 1, never cross a nerve. Rule number 2, never breach a vessel. Once we have studied the films in various sections and views, we should develop a 3D mental image of the anatomy in question, the lesion, the extent of the lesion, infiltration, vascularity, neighboring structures like cranial nerves and vessels, and the nasal corridor to reach the same. Though 3D reconstruction images provide us a fair 3D picture. This vivid 3D reconstruction helps us to perform surgery better. Pictures that shock the world. It is said a single picture can speak 1,000 words. I want to mention few pictures which shock the world. First picture, picture of a naked young girl running during napalm bombing of Vietnam. Second picture, a vulture preying on a malnourished child in Sudan. Third picture, a child victim of war in Czechoslovakia. And the fourth one, the Syrian refugee child which drowned recently. These pictures have had the greatest impact on the sane world. Pictures that changed anterior skull-based surgery. I've shown you the pictures which shocked the world. Similarly, I would like to show two pictures which changed the way the anterior skull-based lesions were treated. They are pictures depicting various approaches to the skull base. First picture, a sagittal section CT scan showing sagittal approach to the skull base, and the next a pictorial diagram depicting coronal approach to the skull base. With this basic background about imaging for endoscopic skull base surgery, we will study various imaging modalities with respect to surgical approaches used for anti-endoscopic skull base surgery. To begin with, we will study sagittal approaches. Transorbital approach. Sagittal approaches are also known as midline approaches. They extend from the transfrontal approach in the anterior extreme here up to the transorbital approach in the posterior extreme here. We will begin with Transorbital approach, most common approach used by the anti-skull base surgeons today. Pituitary adenoma, purely intracellular craniopharyngiomas, and Rathke's cleft cysts are excised using this approach. We will see some case studies to examine how we can approach these lesions. Case study. This 50-year-old female patient presented with bilateral decreased vision of 3 months duration, gradually progressive. MRI T1 weighted images showed a isodense mass in the cella, enlarging the cella, growing superiorly, and pushing the optic chiasm or displacing the optic chiasm posterior superiorly. You can also appreciate this in sagittal reconstruction T1 weighted images, cella enlarged, and this is contrast enhancing T1 weighted images. You can see there is heterogeneous variation by the tumor, and you can see this cella is enlarged, however the cella bone seems to be intact. Again, you can appreciate the same picture in T2 weighted images, and this was pituitary macroadenoma. And what you can also notice is left side, the left internal carotid artery is encircled. That means this tumor is involving the cavernous sinus also. Snowman sign in neuroimaging refers to configuration of pituitary macroadenomas, which are soft tumors due to indentation at the diaphragmatic cella, giving them a snowman configuration, or number 8 or dumbbell configuration. This feature helps in differentiating these tumors from meningiomas. Here are few case studies of variants of pituitary macroadenoma. The first MRI picture shows a pituitary macroadenoma with the involvement of the right cavernous sinus and encircling internal carotid artery. The second MRI picture shows large, mostly solid enhancing mass encircling the pituitary fossa and extending into the suprastellar cistern, elevating and compressing the optic chiasm. The third picture, again another large, mostly solid enhancing mass enlarging the pituitary fossa here and extending into the supracellular cistern, elevating and compressing the optic chiasm, and the central area demonstrates cystic change with some intrinsic high T1 signal. The fourth picture demonstrates a pituitary macroadenoma with hemorrhage within it. The fifth MRI film shows a pituitary macroadenoma with erosion of the sphenoid bone. This last film, this is a contrast enhanced CT film in arterial phase, shows large markedly enhancing cellular mass extending into the supracellular region and causing displacement of surrounding structures. In this case study, MRI of the brain showing a mass in the supracellular region which is variegated both in T1 and T2 signal with regions of intrinsic high T1 signal and cystic areas and solid enhancing areas. This is diagnostic for craniopharyngioma. In this case study, a cystic lesion occupies the anterior part of the pituitary fossa, displacing normal pituitary gland tissue posteriorly and somewhat to the left. It is of low signal intensity on T1 images and does not enhance, and is of high intensity on T2 images and demonstrates 2 to 3 millimeter hypointense nodule antero-inferiorly. The optic chiasm may be in just contact in the midline by the dome of the cyst, but there is no evidence of extension into the cavernous sinuses on either side. This is a case of Rathke's cleft cyst. Coming to the nasal corridor in Transorbital Approach, the nasal corridor involves three parts: the nasal cavity proper, the sphenoid sinus, and cella. Here in axial section MRI, the nasal corridor shown here, and in the sagittal section MRI, the nasal corridor is shown here, and this in blue color is the sphenoid, and the green one is the cella. In the nasal corridor, we need to assess preoperatively the configuration of the nasal septum and see if there is any deviation, and look for turbinates, assess if there is any turbinate hypertrophy, and also look for any nasal or sinus pathology, and also assess if there is any hindrances for harvesting a nasoseptal flap. In the sphenoid, assess sphenoid pneumatization and see what is the extent of the pneumatization. See if there is pneumatization of the pterygoid processes and also descent, median nerve and maxillary nerves, and look for pneumatization of the anticlinate process and presence of horizontal septa which represents the Onodi cells, and look for any descents of the optic nerves as seen here, and also see if there is descents of internal carotid artery as you can see here. Continuing with the sphenoid, sometimes there may be absence of intersinus septa. That is a good sign, but sometimes there may be multiple septa like this with the sinus disease. We may have to clear all the septa, and sometimes septa may be intersinus septa may be ending on an optic nerve or on an internal carotid artery. If we are not careful, we could easily injure these vital structures. Coming to the cella, we have to study what type of cella is there and study bone thickness and see if there is any bone erosion. There may be expansion of the cella due to the lesion or pathology, and study proximity of the cella to various neurovascular bundles around it, and most important, what type of cella. There are three types of cellas have been identified: conchal, precellar, and cellular, the conchal type of cella where this the sphenoid sinus is only a small air cell in front of the cella here. So we will have to drill large amount of bone before we reach cella in this case, and pre-cellar type of cella here, this is the cella, and the sphenoid sinus pneumatization remains anterior to the cella as shown here, and the cella type, common type, favorable type for us, where the sphenoid is very well pneumatized around the cella as shown here. We should have a preoperative understanding of cella type to do surgery efficiently. In all pituitary tumors or pituitary lesions, we need to study cavernous sinus extension carefully. NOSP et al. They classified these cavernous sinus extension into 5 grades starting from 0, where the tumor is remaining medial to the median carotid line as shown here. Here the grade 1 where the tumor is near to the median carotid line, okay, and grade 2 where the tumor is reaching lateral carotid line but not going beyond that, and the grade 3 where it has crossed the lateral carotid line but not encircling the internal carotid artery, whereas grade 4 this is encircling the uh, uh, internal carotid artery, such as this one where the lesion has encircled the internal carotid artery. These tumors poses a challenge, and vital structures like internal carotid artery and sixth cranial nerve are at risk, and sometimes this may require additional approaches like cavernous sinus approach, paracellular approach. Yeah, coming to the safety and efficacy in Transorbital Approach, we should have a very good understanding of the pituitary lesions to the neighboring structures, important laterally to the cavernous sinus and the internal carotid arteries, superiorly the pituitary stalk and the optic chiasma, optic nerves, and also far lateral here, uh, the sixth cranial nerves. In this shows left lateral view of the cavernous sinus and the structures within the cavernous sinus. So we need to understand the relationship of the tumors to these vital structures before we embark on surgery to prevent damage to these structures.
Transplanum approach. Transplanum approach is the next common approach used in endoscopic anti-skull base surgery. Either it is used sometime as an isolated approach or sometimes along with the Transorbital approach or transcribriform approach. The indications for transplanum approach are craniopharyngiomas and tuberculocellae meningiomas. Case study in transplanum approach. This 20-year-old male patient presented with history of headache, giddiness and blurring of vision. There is an MRI. There is a well-defined space-occupying lesion which is seen in supracellular and cellular region, which reveals predominantly solid and partially cystic components within it. The pituitary gland is not seen separately from mass lesion. On post-contrast study, intense heterogeneous enhancement is seen in solid portion of the lesion with few non-enhancing areas. It is encasing both adjacent internal carotid arteries bilaterally, as you can see it. And this is a case of craniopharyngioma. Second case study. This 67-year-old male patient presented with history of bilateral visual deterioration and headaches. Perimetry revealed bitemporal hemianopsia. MRI showed a midline mass with intermediate T2 signal at the tuberculum cellae, displacing the optic chiasm and extending posteriorly to the pituitary stalk. However, the pituitary itself appeared normal. This is a case of tuberculum cellae meningioma. Nasal corridor or approach in the transplanum approach. Here you have to study, like in Transorbital approach, the configuration of the nasal septum and configuration of the turbinates, both inferior and middle turbinates, and also the aeration of the ethmoid sinuses. Note if there is any pathology in the sinuses. And you also have to study a parasagittal and sagittal sections of CT scan. And you should notice one thing here. The skull base, the anterior skull base is higher up. As we go posteriorly towards the planum, it becomes lower. And one more thing, the anterior skull base here at the cribriform plate is very thin, but at the planum side, this anterior skull base is more thicker, as you can see here. You should also notice presence of horizontal septa within the sphenoid, which indicate the presence of one-OD cells. You should also notice any dehiscence over the optic nerve, as you can see here, or internal carotid artery and cavernous sinus. You must study these points without fail for this approach. Transplanum approach is an efficient approach, but we should be careful. We should observe safety measures. We should be careful with the optic nerves, as you can see here, and also optic chiasm and their respective ophthalmic arteries, internal carotid arteries, which are lateral here, internal carotid artery, also anterior cerebral arteries and its branches, A1, Hubner's artery, and anterior communicating arteries and perforators. We need to take care of these structures. Trance cribriform approach, an anterior approach. We commonly perform repair of CSF leaks and excise meningocephalocele and prevent leaks, which are mini cribriform approaches. But the main trans cribriform approach we may require in esthesioneuroblastoma or invasive sinonasal malignancies and anterior fossa meningiomas. Case study: this 45-year-old female patient presented with history of anosmia and nasal obstruction since 2 to 3 months. An MRI, as you can see, the markedly enhancing irregular midline mass epicentered at olfactory fossa and extending intracranially as well as into the nasal cavity. This is a case of esthesioneuroblastoma. Second case study in transcribiform approach. This 55-year-old female patient presented with nasal obstruction and anosmia. Large anterior cranial fossa tumor mass filling the olfactory groove here, and it also demonstrates prominent spoke wheel vascular supply, and also there is CSF cleft sign, as you can observe here. This is a case of anterior skull base meningioma. Coming to the nasal corridor or approach, for the transcribiform approach, you need to study again the nasal septum, the turbinates important, the middle turbinate which you are going to excise, and also configuration of the anterior skull base, study the Quiros classification, and also study the fovea and the cribriform plate, and most important here is the configuration of anterior and posterior ethmoidal vessels, which we are going to cauterize, and also we should study on cerebral angiogram or CT angiogram or MRI angiogram configuration of the vessels in the anterior cranial fossa. Very important. Coming to the safety and efficacy in transcribriform approach, the main thing we need to take care initially is anterior medullary artery. We should identify, isolate it and cauterize it. We should ensure that the anterior medullary artery, cut end of the anterior medullary artery doesn't retract into the orbit and create a retrobulbar hematoma and a threat to patient's vision. Also, we need to take care of posterior medullary arteries and anterior cerebral arteries A2 and the branches frontorbital and frontopolar arteries, and also bilaterally we have to take care of the orbits. Transfrontal approach, which is an extension of endoscopic sinus surgery. We have to use this approach in chronic frontal sinusitis or frontal fibroosseous lesions and frontal sinus mucoceles. For transfrontal approach imaging requirements, we need CT scan in all views sections, that is, we need a coronal section, we need axial sections, and also sagittal reconstructions. MRI is required to study soft tissue pathology, soft tissue structure of the tumors. Case study, this is a case of frontal sinus osteoma, as you can see here, which was excised using transfrontal approach. It is nothing but modified Lathrope's or draft 3 procedure. Nasal corridor for transfrontal approach. This we need to study on CT scans in coronal, axial and sagittal reconstruction. We need to study the nasal septum and its configuration, specifically superior end of the nasal septum, which we may excise to obtain an approach to transfrontal approach, and also configuration of the agar cells, the nasolacrimal duct on either side, and the frontal sinus itself, the pneumatization of the frontal sinus, extent of the pneumatization, number of frontal sinus cells, and also any presence of interfrontal cells, and also above the agar the frontal cells. We should also study the type of frontal sinus drainage, whether it is middle meatus type or infundibular type. And we should also study the dimensions and boundaries of the frontal recess, which is bounded anteriorly by the agar cell, posterior of the agar cell, and posteriorly by the anterior wall of the bulla ethmodalis. If the superior end of the bulla is not complete, sometimes frontal recess can directly communicate with the lateral sinus. One should also study the frontal cells. There are 4 types of frontal cells. Type 1 cells, when there is single cell above the agar cell, as you can see here. Type 2 cells, when 2 or more cells are present above the agar cells. Type 3 cell, when a large cell is present above the agar a type 4 cell which is in the frontal sinus but away from the frontal recess, isolated cell. We need to remember these cells in order to get a good approach to the frontal sinus. We should also study the configuration of frontal drainage system. There are 2 types of drainages that can occur depending on the superior attachment of the uncinate process. As you can see here, this is the uncinate process. If it is attached to the lamina propria, as you can see here, the frontal recess drains into the middle meatus. But if the superior end of the uncinate process is attached to the skull base, the frontal recess drains into the ethmoid infundibulum, as you can see here. If the superior end of the uncinate process attached to the middle turbinate, as in this case, again the frontal recess drains into the infundibulum, ethmoid infundibulum. There are 2 types of drainages of the frontal recess, the middle meatus type and infundibular type. Coming to the safety and efficacy in transfrontal approach. Transfrontal approach is an efficient approach if you are using modified Lathropes or draft 3 approach, but we should be careful about the anti-eighth metal artery. We should ensure that the cut end of the anti-eighth metal arteries does not retract into the orbital cavity. Transclavial approach. Transclavial approach is used for both extradural as well as intradural pathologies. The extradural pathologies that can be addressed through transclavial approach are chordomas and chondrosarcomas. The intradural pathologies where this transclavial approach can be used are the meningiomas or craniopharyngiomas which are anterior to the brain stem. Case study for transclavial approach. This is a case of petroclavial meningioma. You can see both pre-op and post-op picture where this petroclavial meningioma has been excised using transclavial approach. In transclavial approach, we should ensure safety to the brain stem here and cranial nerves 2, 3 and 6 cranial nerves which are in the close vicinity, and also basilar artery and vertebral arteries and superior cerebellar arteries. Transodontide approach, which is in the posterior extreme of the all sagittal approach to the ventral skull base. This approach is used for resection of odontoid process in degenerative or inflammatory diseases and in congenital compressive disorders. It is also used for exposure of the ventral medulla and upper cervical spinal cord. The transodontide approach is also used for foramen magnum meningiomas. Case study for transodont approach. This is a case of foramina magnum meningioma which has been approached through transodontide approach, as you can see here, and these are post-op MRI. You can see the posterior part of the septum has been removed here to get an access, and the tumor has been excised through transodontide approach, as you can see here. The approach or nasal corridor is like any other approach for ventral skull base. Specifically, we should study the configuration of the nasal septum and the clivus, and we should remember that we cannot go beyond the K line, Kassam's line here to approach in the transodontide approach. In a transodontide approach, we should ensure safety to vertebral vessels and posterior inferior cerebellar arteries, the brain stem and lower cranial nerves. Coronal approaches to the ventral skull base. These are paramedian or lateral approaches. Initially there were 5 major approaches, coronal approaches, but now few more have been added up. The first approach or zone 1 approach, this is also known as medial petrous apex approach. The zone 2 approach, this is known as petroclival approach. Zone 3 approach, this is suprapetrous approach for the anterior part of the Michel's cave. Zone 4 is approach to the cavernous sinus. Zone 5, this is for the infratemporal fossa. Now the 2 more have been added up here. This is transcondylar approach, mainly for the medial part of the condyle and also to the hypoglossal canal, and jugular fossa approach. This is the post-styloid compartment of the neck. In this part, these are the important approaches here. Imaging requirements for coronal approaches, both CT scan as well as MRI are important. CT scans in axial coronal as well as sagittal reformations are required to study the anatomical configuration of the approaches, various structures in the approach, and for MRI to understand the pathology, its epicenter and extent of the pathology. Yeah. It is very important to study the nasal corridor for these approaches on both CT and MRI. On CT, we need to study the configuration of the nasal septum, the turbinates, and aeration of the sinuses, if there is any pathology in the sinuses, that study the pterygoids, configuration of the pterygoids, the clivus, and infratemporal fossa. Here on MRI as well as CT and on angiogram, we need to study the carotids, the pathology, carotids specifically, we need to study the parapharyngeal carotids and paraclival carotids and paracellular carotids. We need to study the pathology, extent, epicenter, and involvement of the adjacent structures. We need to study these in detail. The Zone 1 approach, which is also known as medial petrous apex approach. This approach is used in chondrosarcomas in this region or petrous apex cholesteatomas. Zone 1 or medial petrous apex case studies. This axial section CT angiography showing a left petrous apex lesion with expansion posteriorly and medially towards in the direction of the sphenoid sinus. This is an example of a cholesterol granuloma that can be resected by an endonasal endoscopic approach, medial petrous apex approach. This is a cholesterol granuloma. The second case is this patient presented with right-sided sensorineural hearing deafness, headache and tinnitus. A right petrous apex well-defined lobulated bordered space occupying lesion is seen. The lesion shows hypointense T1 signal, however, and T2 bright T2 signal is seen, but post contrast there was hardly any contrast enhancement. This is a case of petrous apex cholesteatoma. Unlike other case, this case is the lesion far more laterally placed and it may be often difficult to approach such lesions through endonasal endoscopic medial petrous apex approach. Zone 1 or medial petrous apex approaches, we need to ensure safety to internal carotid arteries and the sixth now at the duralos canal. We need to understand the anatomy of the cavernous sinus and the structures within the cavernous sinus. Zone 2 approach or petroclival approaches. These are used for chondromas or chondrosarcomas or petrous apex cholesteatomas or petrous apex meningiomas. Petroclival approach or zone 2 approach. Zone 2 petroclival approach case study. This 54-year-old female patient with right lower cranial nerve palsy with right trigeminal neuralgia and chronic headache. On MRI, patient had a right petroclival homogeneously enhancing mass lesion as seen here. The lesion causes effacement of the right ambient cistern with significant right-sided brainstem compression, and patient also had invasion of right Michel's cave and right cavernous sinus as well. Also encasement of the right internal carotid artery, cavernous part of the internal carotid artery, and also the lesion displaced the basilar artery also. This is a case of petroclival meningioma. We need to study and ensure safety, specifically the laterally to 7th and 8th nerves, the inner ear nerves, very important in this approach. The zone 2 approaches, And also we need to ensure superior petrous internal carotid artery, which will be somewhere here, and also inferolaterally the hypoglossal nerve. We need to ensure safety for the structures. Zone 3 approach or suprapetrous approach for the anterior portion of the Michel's cave. This is also known as quadrangular space approach. This approach. This is used for invasive adenoid cystic carcinomas, juvenile nasopharyngeal angiofibromas, meningiomas, schwannomas, and invasive pituitary adenomas. Zone 3 or suprapetrous approach to the anterior portion of the Michel's cave. Here this T2 images showing bright signal. This is a case of schwannoma, T1 with contrast. There is no enhancement showing cystic component. This is a case of Michel's cave schwannoma which was approached through suprapetrous approach to the anterior portion of the Michel's cave. In zone 3 or suprapetrous approach to the anterior part of the Michel's cave, we need to ensure safety to VT or maxillary division of the trigeminal nerve and also the V3 mandibular division of the trigeminal nerve, and most important the internal carotid artery. Zone 4 approach is also known as cavernous sinus approach, which is rarely used. This is used in apoplectic pituitaries or pituitary adenoma with cavernous sinus extension. Also in case of cavernous sinus syndrome with third, fourth and sixth nerve palsies. Zone 4 or cavernous sinus approach case study. This pre-op T2 images showing a petrocavernous chondrosarcoma. First time it was operated via a subtemporal approach with a cavernous sinus tumor remnant. Second time via a trancellular endoscopic trancellular endonasal approach completed the tumor removal without any postoperative cranial nerve or pituitary deficit. In zone 4 or cavernous sinus approach, we should ensure safety to cranial nerves, mainly 3, 4, 5 and 6 cranial nerves, intercarotid artery with its sympathetic fibers and also inferior hypoglossal artery. We should ensure safety for these vessels. Zone 5, also known as transpterigard or infratemporal fossa approaches, is mainly used for invasive carcinoma, CSF leaks from the lateral recess of the sphenoid, and encephaloceles, schwannomas, and skull base meningiomas. Zone 5 or transpterigard or infratemporal fossa approach case study. This first film a computerized tomography axial section showing asymmetry in the pterygopalatine fossa. You can compare on both sides. The right side showing loss of normal soft tissue architecture compared with the left side. The next film, the axial magnetic resonance image, shows a well circumscribed mass in the right pterygopalatine fossa enhanced with gadolinium with a slightly heterogeneous appearance. The kernel T2 weighted images showing a well circumscribed lesion in the right pterygopalatine fossa enhanced with gadolinium and with partial liquefaction. This is a case of schwannoma in the pterygopalatine fossa. In zone 5 or transpterigard approaches, we need to ensure safety to internal maxillary artery and its branches, Vidian nerve, trigeminal nerve V2 and V3. Branches we need to ensure safety, and also for supraorbital fissure superiorly. Zone 6 or condylar or hypoglossal canal approach. They are used for invasive carcinoma, paragangliomas, and schwannomas and skull base meningiomas. Zone 6 or medial condylar or hypoglossal canal approach. Case study, this is a case of metastasis to the condyle, right side condyle. You can see here, which was approached through right side transcondylar hypoglossal canal approach, and the tumor was excised. In zone 6, we need to ensure safety to internal maxillary artery, internal carotid artery, mainly parapharyngeal and petrous segments, The trigeminal nerve, the 12th cranial nerve exiting from the hypoglossal canal inferiorly and laterally, and the lateral limit of the zone 6 is ascending pharyngeal, internal carotid artery and hypoglossal canal. Zone 7, a jugular foramen approach. This is used mainly for invasive carcinoma, paragangliomas, schwannomas and skull base meningiomas. Zone 7 are jugular foramen approaches. This is coronal section MRI T1 images showing a jugular fossa tumor, a schwannoma, T2 weighted images showing bright signal and contrast enhancing T1 images. In zone 7, we need to take care of internal maxillary artery and internal carotid artery, mainly the parapharyngeal and the petrous segments, the trigeminal nerve, the 12th nerve, which is exiting the hypoglossal canal inferiorly and laterally. Coming to the efficacy, the lateral limit of the zone 6 is ascending pharyngeal, internal carotid artery and the hypoglossal canal. Transorbital approach. Transorbital approach can be used in sinonasal lesions that are invading the posterior wall of the orbit, such as sinonasal malignancies, and for decompression of the optic nerves in the presence of unresectable intraconal pathologies, and also for accessing intraconal diseases with the goal of resection, such as schwannomas, cavernomas, and meningiomas. Transorbital approach case study. This is a patient presented with right-sided retroorbital pain and decreasing vision. On contrast enhanced CT scan, there was a enhancing mass in the petrous apex. In the bone window, there was pathology within the sphenoid sinus on the right side. Here you can appreciate the pathology in the right sphenoid sinus, which is extending into the right orbital apex. In the same case, MRI confirms the pathology in the sphenoid sinus, which has eroded the lateral sphenoid wall involving the right cavernous orbital apex and also superior orbital fissure, as we can appreciate here. This was a case of squamous cell carcinoma of the sphenoid sinus on the right side. Coming to the transorbital approach, efficacy and safety, we need to take care of the optic nerves, very important, anterior and posterior ethmoidal arteries, and also ophthalmic artery with its central retinal branch. Thank you very much for your kind attention. I welcome you all to visit my place, my hospital, and the magnificent fort of Chitradurga.